Dr. Shelby McGuire with Valley Health. I'm one of the psychologists here, and I work with pregnant and postpartum women, and currently run groups and do individual therapy as well with pregnant and postpartum women.
So my name is Jessica Offhon. I'm a nurse practitioner, and I've been the nurse manager of the MOMS program in the NTU for the last couple of years. To my right is Talisha Franklin. She is coming on. She is the new nurse manager of both programs, the NTU as well as the MOMS program. Rachel Goddard in the gray. She is a licensed professional counselor. She does all of our therapy appointments. And then the next one is Courtney Wellman. She's our nurse practitioner, and she does all the medication management, any medical treatment, medical services, referrals that patients might need.
So the idea was that we talk about some of the most frequently asked questions from some of the mamas that we get to work with.
Yes. Okay. So the MOMS program is something that we do where Courtney gets consults here in the hospital, and she goes and talks to them, and she sees whether or not they want to come into the MOMS program, if she can help them in any way with referrals and different things like that. We're an MAT program, but we also, Courtney prescribes for other things besides that. So we don't have just people here that are on, let's say, Suboxone or Vivitrol or something like that. So she can do other things, which is great because then we can do the full gamut of mental health and everything like that. I do the counseling, group counseling, and I do individual therapy.
Can you tell a little bit more about how someone were to get into the MOMS program, what that kind of looks like?
So we are strictly for postpartum women. The way we get most of our consults, you can do a self-referral. A patient can just call us. Sometimes CPS will call us. But the way we get the majority of our consults are if a mom delivers a baby here and her urine drug screen comes up positive for anything. And when I say positive, it can be prescriptions. It's not just illicit drug screens. You know, people are prescribed medications that can pop up, and we get an automatic consult. So Courtney is our nurse practitioner, and she will, when she gets the consult, she'll go meet with the moms and discuss treatment options with them if that's something that they're interested in. Do they want outpatient, inpatient, any community referrals? If they're interested in the MOMS program, we're a 1-year program. Like I said, it strictly sees postpartum women. So they'll do 2 individual therapy appointments a month, a group therapy once a week. We do all that here. We're building on. We've also got a follow-up clinic for the babies, just for developmental surveys and stuff like that, so that we can do the whole dyad care and see how mom and baby are both doing together. You do not have to have custody of your baby to be here. Only requirement to be in this program is you have to be within 6 months postpartum at your time of admission. And from that point on, you can stay for up to a year. And then we would do a warm handoff to another program of your choice, whether it's closer to home or just something more long-term, whatever that mom wants.
The moms that I work with frequently ask about the medications that are used in the NTU, wondering why certain medications are used, in what situations might other medications be used, and how that maybe impacts the length of stay for the baby. So if you could talk a little bit about that.
Sure. So it really depends. It's all individualized per the baby. Obviously the first thing we look at are substances exposed to during pregnancy, and it's not just within the last couple weeks. It goes all the way back to approximately 20 weeks of pregnancy. What all the exposures could have been. A lot of times honesty helps the babies out the most and the moms, because it helps get the right treatments on right away so that we can start weaning right away. And, the baby's progress will be a little bit quicker. Obviously, with any opiate exposures, whether it's heroin, fentanyl, Suboxone, Subutex, any opiates, we use methadone here. That is approximately a 30-day wean. And it depends on the babies. Some babies go right through it, some babies hit a few bumps in the road and we have to slow down. Other medications that we use, again, it depends on all the exposures. Sometimes it can still be strictly opiates, but the baby might need clonidine or phenobarbital. It just depends on the baby's withdrawal process, how they metabolize it, how they tolerate the withdrawal, that sort of thing. Neurontin, if there's neurontin exposure, we can treat the baby with neurontin as well. And obviously, the more medicines that we add on, the longer the length of stay is going to be, because you have to wean all of those medications. One common myth, I guess, that we see and hear a lot is moms think, and it's because they're told a lot of times by their doctors or other moms, that they've decreased their Subutex dose to 2 milligrams a day, so their baby's not going to withdraw as much or won't need treatment. And what we found and what studies are showing is that it's not dose dependent as far as the withdrawal process. It's the baby. The baby guides our treatment and the weaning procedure.
And another question that's often asked is about the scoring whenever baby's born and the monitoring and what that process looks like. So if you could explain that a little bit.
We're currently in the process of looking at changing the way we score and stuff. Right now we use what's called the Finnegan scoring system, which has historically been what most places used. It's a scale back from the 1970s. So it obviously needs revised a little bit. We are going to start looking towards a little bit of eat, sleep, and console. And that just puts mom in control. We need to, mom is the best medicine. The more mom can be here, and the more that mom is with her baby, those babies do a lot better. Breastfeeding, if mom wants to breastfeed and she qualifies to breastfeed, those babies do better. And we try to encourage that. We're making, just in the last month, some changes about, with the scoring, letting moms room in. Those baby scores are better when mom can room in and be with the baby all night. We started, it used to be we would score every 3 hours. You would wake a baby up, the baby's hungry, and you would score them. Well, their score's going to be high because they're hungry. So we have made some changes to where you don't score a baby until after they eat. We're not waking babies to be scored, that sort of thing. But some of the things they get scored for is mottling skin or nasal stuffiness, rigidity, sneezing or tremors, diarrhea, anything like that the babies can get scored for. So we're starting to modify, for example, the loose stools. If the baby's breastfed, we don't want to score for that. If the baby is 30 days old, we don't want to score the baby for not sleeping, because that's a normal baby. They don't sleep as much. So we're starting to make modifications as far as that goes with the scoring.
And you mentioned mom being the best medicine often, and some about breastfeeding. So I was wondering about the protocols for breastfeeding, things we might be looking for mamas to be able to engage in that with their baby.
Sure. The biggest help is if mom can bring her the last 90 days prior to delivery of her drug screens with her when she comes to deliver. If she's able to keep that with her, that she'll be able to breastfeed right out of the gate. What we say is 90 days of consistent drug screens, meaning you're only positive for what you're prescribed, and you're negative for marijuana at the time of delivery. So within those 90 days, you can be positive for marijuana, but you have to be negative at delivery. And we made that kind of caveat because it binds to the fatty tissue and obviously would stay in the breast longer. So we just want to make sure at the time of delivery, mom is negative for that. So as long as she is in a treatment program, she is what we call stable in a treatment program, which we like 90 days of clean, consistent drug screens. If she doesn't have them with her, she can sign a release. We'll get them for her. but a lot of times that takes time. Because it could be on the weekend, or the programs aren't in, or you've got to get the right person at that program to actually fax the results over. So that kind of takes away from moms and babies breastfeeding experience, because you want them to get to start right away if that's something they're interested in.
And you mentioned some about rooming in. What are some of the protocols for that? Anything that moms need to do ahead of time to prepare for that?
So right now we are scheduled to undergo a renovation on the NTU, and it's to be completed by the end of the year. So by December 31st is what we're told we should be completed. At that point, excuse me, we'll have all private rooms, and parents are allowed to room in 24/7. Currently, we encourage rooming in for all parents. We have to use, it's on our unit, but it's technically owned by mother baby. So as long as they're not using that unit, we allow moms to room in. They can room in every single night if they're not, as long as they don't have to open that other unit, which is very uncommon that they have to open it, but still a possibility. The only time that moms can't room in with their baby is if we start a new medication on the baby, or we have to increase the dose. We require that the baby be in the room with the nurse for 24 hours so they can be monitored just to see their response to the medication. But otherwise, as long as mom is doing well, there's not a requirement necessarily that she be in a program or anything like that written in stone for her to room in, just as long as she's in a good place and she's taking care of herself and her baby. Have to follow safe sleep guidelines. That's one of the things that will terminate rooming in, is if we continually go in and safe sleep not being followed or something like that. But we encourage anybody can room in as far as moms.
And a lot of moms are asking about the impact of COVID-19 on rooming in and who can visit. So can you speak to that a little bit?
Sure. It affected us a lot in our visitation policies and that sort of thing. Used to, moms could come in, they could have a designated significant other, as well as dad, if he were involved, could designate a significant other. And then that was all cut off with COVID. They just opened up our guidelines a little bit yesterday. It's still for parents and guardians only. So parents and guardians, as we define them, are birth parents, and birth parents as in dad is on the birth certificate, and or mom will sign a release of information that is dad. And so if he hears any information while he's here, it's okay to speak freely. Or foster parents or adoptive parents. Those are how we have defined parents and guardians. So as of yesterday, both parents can come in, they can be at the bedside at the same time, and they can come and go. It used to be, if you left the hospital, you couldn't come back until the next day. So they just opened that up yesterday. So it's getting better.
That's great. And you mentioned different family members visiting. Lots of moms that we work with often wonder about how to talk to baby siblings about the NAS process, about what that means, the extended stay, and whether or not siblings can visit. Can you speak to that at all?
Mm-hmm. We had just developed a sibling visitation program, and then COVID happened. So we never really got to implement that. But we do have a sibling visitation policy that we hope we can open up once everything gets back to whatever normal is going to be. But right now, siblings can't visit until we get the clearance from the hospital. In a normal situation, other than flu season, when it's flu and RSV season, we would stop sibling visitation. But other than those few months, we would allow sibling visitation. Once the renovation is completed, it won't matter because it'll all be private rooms. But prior to that, if we're able to start sibling visitation, we would move the baby to a separate room to where the family could have time just to themselves and introduce the sibling that way.
And a lot of women that we work with are curious about expectations for CPS involvement. So they're wondering if you have any information on that, any guidance or suggestions for moms who will be going through that process.
I wish. I mean, every worker, every state, every county, it's so different. The one common theme that I can speak to, and you guys maybe can speak to something else, is they want mom to be in a program. It doesn't necessarily matter what type of program, but as long as she is in some type of treatment program and actually showing up to her appointments. A positive drug screen in itself does not determine anything, but just the pattern. The pattern is use getting less frequent, or levels decreasing, that sort of thing. But it is so sporadic as far as what the CPS expectations are, at least from what I've seen. I don't know if you guys can speak to anything different. Or
I mean, the case is opened right away.
Right.
I mean, have you ever? We definitely see cases opened if they come in and screen. So a CPS case is opened even if you're in the Suboxone program sometimes.
Well, they've already got, yeah.
Subutex, yeah. So that's one thing. That's even if they're in a program and it's Subutex, we've seen cases be open. So
right. Yeah.
That's I think maybe one of the things that the moms freak out about is I'm already in a program. I'm, let's say, in the MARC program, and I'm on Subutex, and I come over to the mom's program, I have the baby, and here I am, and I'm still dealing with CPS, or I got a case opened on me. But again, like Jessica said, history has a lot to do with it. And that's why she's saying the case by case, because depending on what they have in their past, if there's a termination or not, it's going to really change some things, as far as parental rights and things.
So as long as even if they're in a program, even if,
That's what I've seen, but it's like you said, it's case by case.
So here in Cabell County, if a mom delivers and has a positive urine drug score, I think it's West Virginia, it's an automatic CPS referral. We are seeing, finally, not very frequently, but it is starting, the tides are starting to turn, that when the social worker reports these cases to CPS, we have seen some where mom's been stable in a program for, however long, and she's been consistent on her urine drug screens, and they won't open a case. They'll screen it out, is what they call them. So we are starting to see some of that, which is great, because these moms are doing what they're supposed to do. And then when you get, kind of smacked with that CPS consult, that you feel like you've done something wrong when you really haven't. You're doing everything that you can do. But as far as advice is, try to look at them like they're trying to help you and your baby. When you look at it as a punishment, which I get why we can look at it that way, but when you look at it as a punishment, you resent it and it's harder. But if you look at it as just another resource, they can help. They really can.
That's a great way to look at it. And that affects the interactions that you have with the CPS workers too, which can make the process easier on you.
Yeah.
And CPS has access to a lot of funds that can really help them. So they can help with housing and getting a job and transportation. And I mean, there's all kinds of things they can help them with. And so, we try to promote that, because they usually are pretty upset that a case is, even someone walks into their room and says there's going to be even an investigation, they're upset. So.
Sure. Kind of along those lines, are there any support services that are offered through the hospital or upon discharge that the mamas can take advantage of?
Yeah, we use, upon discharge, there's always, if mama is far away, we have the Ronald McDonald House here, that if the baby does have to stay, that mom can stay in the Ronald McDonald House as long as she is stable in a program. And let's see, we use the Marshall Peer Recovery Coaches, the family navigators. So as far as, I can just speak to once they're in the mom's program, Courtney they automatically get a peer recovery coach consult, and Cassie will come meet with them and see if there's anything she can help with, and she'll follow them throughout their recovery journey. And same thing with the family navigators. They get an automatic consult once they start the program, and the family navigators will come here, see if they can help them with anything, housing, transportation, food, baby items, things that mom needs. It doesn't have to be about the baby. It can be about mom. So those are probably the main resources. We have a few funds, different funds in the moms program set up. We found that Medicaid, at least West Virginia Medicaid, has started completely randomly charging people $2 to $3 for their Suboxone. And not that that is a huge amount of money, but if you're not prepared for it when you go to pick it up, you may not have it. So we will help if a situation like that comes up. We have a mom's fund set up to help with prescription coverage. If they need baby items or items for them, we have a fund set up that we can help with that. We've got car seats, we've got Easter baskets for other children, or just any items that some of us take for granted. We can help with those sorts of things too.
Gosh, it's great to have all of those support services together in
Yeah.
the same place. Yeah, that's wonderful. Do you guys have any advice for moms to expedite the NTU process or make the process easier for babies?
Be honest. Yeah, just be honest. Even when you don't want to be and you are embarrassed or whatever the situation might be, just be honest. Know and write offhand what your baby has potentially been exposed to. And honesty may be, you know what, I used meth for 3 months. I just thought I was using meth, but yeah, there is a possibility it was cut with, whatever. Just to be honest. If you can come with your drug screens, that's great. Especially if you want to breastfeed or stay at the Ronald McDonald House, bring those with you so you don't have to wait on somebody to get them. And room in.
That's a great idea to bring the drug screens
Yeah.
ahead of time. Anything else you would suggest for moms to prepare ahead of time to bring with them?
Prepare for your baby to stay. Expect the worst, hope for the best. I think a lot of our moms come in here thinking their baby's going to go home. And while that is the ultimate goal, realistically, that's not always going to happen. So prepare to stay for 5 to 7 days, no matter what. And then we just watch the baby at that point, to make sure they are or are not going to withdraw. But no matter what, prepare to stay 5 to 7 days, because we see lots of moms that don't expect it, and it's almost like they're set up for failure. You're in this vulnerable time. You just had a baby, your hormones are crazy, and then they feel like we take their baby, and and it's hard. It's really hard. I can't imagine. So if you can just come in expecting your baby to stay, and you know what, maybe they won't, that would be great, but realistically, more often than not, that does happen. So I think just realistic expectations helps prepare mom mentally a lot.
And it sounds like taking advantage of those support groups and things
Absolutely.
too, with other women who are going through or have been through similar situations.
Yes.
I hear from a lot of patients that this is the most challenging experience that they've ever been through. Baby going through those things and maybe having other kiddos at home and going back and forth, and it's so challenging.
Yeah, and it's hard. I mean, if you have all the resources in the world, it's hard, much less you take a lot of those supports away and you expect women to do the exact same thing. That's hard. And Courtney just mentioned on the NTU as well, we've got, even if they don't want to do the moms program, we've got the family navigators and peer coaches going around on the NTU. So yes, take advantage of the resources.
Can we talk a little bit about what moms might be able to expect post-birth regarding like medication management, what things to be looking out for that?
I really can't speak a whole lot to that, just because we don't have a lot to do with that on Mother Baby. But it depends. Honestly, it depends on where mom is in recovery, because some moms who are well into their recovery will say, I do not want narcotics. Don't give me any narcotics. Others moms don't say that. We do see most of the time with your C-sections, are they still getting 5 days usually-ish?
It really depends, honestly. They try to stay away from narcotics if possible.
But sometimes your C-section will get a few days of Percocets, but they try to work with mom, and if she doesn't need that, then stay away from it. But if you need it, we don't want you in pain either. So there are the same options, or there can be limited options. It's really, mom just needs to be honest about where she's at in her recovery and talk to her OB provider and what works best for her.
It sounds like a lot of honesty and advocating for themselves and advocating for their babies, being present.
Yes.
Yeah. Okay.
Oh yeah, you don't have to be on medications to be in our program. That's the biggest thing. You don't have to have an opiate use disorder. We take all substance use disorders. It doesn't matter what it is. We'll take you in the program. So you don't have to be on medication management to be here.
That's really
And
good.
another thing too is, when they have their weekly group therapy, that's the same day that they'll see the nurse practitioner. And, anything, she can treat, your minor medical illnesses. If you have a UTI, if you're, you have allergies, or if you're, a cough or whatever, she can help with those sorts of things as well. Depression, anxiety, we treat lots of that. But anything, for the most part, that you can treat at a family practice, she can help you with here. We make referrals, lots of referrals to infectious disease to help get treatment for hepatitis C if that's something mom needs. We try to get them all in with a primary care provider because they're not here long term. So we want them to get that relationship with whether it's family practice, internal medicine, whatever they prefer.
Psychological testing, we refer to that.
Yeah, we refer some patients if needed for psychological testing. We use Marshall Psychiatry if needed. We try to identify those things that are outside of our scope and get them in the right direction.
Can you talk about how maybe tobacco cessation during pregnancy could impact baby stay in NTU, and if you see a difference in some of those babies and nicotine withdrawal?
Yeah, just like I always try to relate it to the way the mom feels. Just like mom feels when she doesn't have a cigarette, baby feels when he doesn't have a cigarette. So it does exacerbate symptoms of withdrawal. Babies can just withdraw from nicotine even when there's nothing else, any other exposures. They're irritable. They don't feed as well. Premature, low birth weights when there's tobacco use during pregnancy. But it definitely exacerbates the symptoms of withdrawal and can make their stay in the NTU longer. For example, if baby is exposed to tobacco and opiates, well, we can give you methadone for your opiates, but that doesn't treat your tobacco withdrawal. And a lot of people just look at it pales so much in comparison to the opiate withdrawal, but it still potentiates those effects and can possibly make the baby need an additional medication like clonidine or something like that to manage symptoms. Or the baby's scores are still high, so you can't wean that methadone yet because they're still having the tobacco withdrawal. So it can make the stay longer. It can, like I said, cause preterm deliveries, low birth weights, that sort of thing.
Have you
And we
seen
do
an
offer
impact?
smoking. Oh, I'm sorry.
Sorry.
No, you're fine.
Go ahead.
We do offer smoking cessation services here in the mom's program as well. Courtney always discusses that with them. Is it something they want to quit? Here are your options. And then at that point, it's up to them if they want to take advantage of that. But it is a service that's offered.
Is there, do you see similar things with nicotine, do you see similar things with caffeine use as well?
Yeah, I don't know if you can talk more about that just with your labor and delivery experience, but kind of the same principle.
Yeah, they do have caffeine withdrawal, and now people drink several Monsters a day and Red Bull energy drinks a day. So even when you're watching them on the monitor, even before they're born, you can see their heart rate, skyrocket as well. And when we're used to drinking caffeine every day, you get headaches, you get the dips, all the things that you get. So they get that too. Certainly, like she said, it pales in comparison to everything else, but it's still a real withdrawal.
Sounds like that's something important to keep asking about in treatment over time. Yeah. Go ahead, Kelly, sorry.
Oh, do you guys have any advice as a fellow treatment provider or community partner for us to be having conversations with our moms, or maybe some things that you encounter, just lack of awareness when they come in? Are there additional topics that we should be touching on that maybe we're not right now, or just any other advice as a treatment provider for patients in the same population?
We get lots of, I was told if I went down to 2 milligrams that my baby wouldn't withdraw. So just education on that the baby's withdrawal is not necessarily dose dependent of what mom is on. If they want to breastfeed, discuss that, prior to delivery, and send their screens with them, 90 days worth of screens, just so they can start right out of the gate, instead of having to wait a few days, because that first initial colostrum and that sort of thing is the big benefit for babies. So if they're able to get that, that's a big deal.
One of the differences in our program too is it's really family friendly, right? We're really focused on parenting and coping skills and other things. Is that right, Courtney? I mean, that's a difference in our program, yeah, for sure, as compared to the others.
Yeah, we used to be able to have the babies in here pre-COVID, and so we could really see, how everyone's doing in the family. So I could look out for attachment stuff while I'm doing group. Courtney could assess how the baby's doing because she's got lots of experience with peds before she came here. So that's one of the big things. Did you talk about gabapentin at all? I'm sorry. Okay, you did.
Yeah.
Okay, because that's one of the big deals is gabapentin. They don't realize that one.
So I've heard that, I've heard moms ask questions about whether what baby goes through in the NTU is dependent on the dose of medication that mom was prescribed. We were wondering if you could talk a little bit about that.
Sure. A lot of our moms are told or read, that if they wean down their Subutex dose down throughout pregnancy, and they're only on 1 or 2 milligrams at delivery, that their babies either won't withdraw, or they won't have to be given medication for the withdrawal, or they want to stay. And what we've found and what studies have found is that the baby's withdrawal process is not dependent on mom's dose. It is not dose dependent. So even if mom quits, say mom is 30 weeks pregnant and she quits using her Subutex completely, well, that baby's still getting it because that is still circulating around and through the cord. So the baby is still getting it until the time of delivery. So it is not dose dependent. And if mom quits after 20 weeks, there is still the very real possibility that baby will withdraw and need treatment.
Thank you guys for all of the support that you provide to our families and our community.
Thank you.
Thank you.
Thanks, everyone.
All right,
Bye.
everyone. Have a good day.
You too.
Thank you.
Thank you.
Thank
Bye-bye.
you.